PHCRC. Due to some last moment emergencies, we have some changes in the panel today. Nevertheless, we have an exciting lineup for you. And with that, I would like to invite Dr. Rajani Ved, our moderator and former Executive Director, National Health System Resource Center of Ministry of Health and Family Welfare in India. She's a visiting scientist at Harvard, T.H. Chan School of Public Health, and has over 10 years of experience in primary healthcare. She in establishing the community health worker program, which is called as ASHA in India. Her expertise spans in policy development stemming from practical technical assistance, implementation research, and design evaluation of large-scale health programs. Over to you, Dr. Ved.
Thank you very much, Manushi. Good day, everybody. It's late afternoon for us in India, and Delhi is India is where Manushi and I are from. Welcome, everybody, to the webinar series, Scaling New Frontiers in Primary Healthcare Through Research and Partnerships, put together by the Primary Healthcare Research Consortium. The Primary Healthcare Research Consortium was set up in 2019, and its vision is to bring high-quality, person-centered primary healthcare through a mechanism of developing and capacitating collaborative research in LMIC and narrowing the research to action gap. We have a global network of partners, and the consortium is funded by the Bill and Melinda Gates Foundation. This webinar is the third in a series of webinars. The first webinar was titled Knowledge Gaps Around Primary Healthcare Quality and Performance Management, focusing on the Eastern Mediterranean region. The second webinar related to primary healthcare organization and models of care with examples from the Asia Pacific region. In today's webinar, we focus on improving performance in primary healthcare systems in LMIC. We have two very distinguished panelists who I will introduce a little later, but we have examples from Mesoamerica, a little bit of a focus on Mesoamerica there, but then also a more generic performance management presentation from Dr. Munar. Primary healthcare performance management is complex. It spans multiple domains, ranging from service delivery, the range of services provided, the quality of primary health care, organization and delivery of services, management of the primary health system. It goes beyond the indicators that we often use to assess the monitoring and looking at outcomes and cost effectiveness of primary health care. It relates to the leadership, the collaboration built between the members of the primary healthcare team, between themselves and the district healthcare system, but also between the primary healthcare team and the community. So you have here different levels of management within a primary healthcare system that is more complex than managing a pure facility-based health system, for instance. So I hope today, after our presentations, we have some discussions on understanding the tools and the frameworks for performance management for primary healthcare. What are some of the gaps in research and what we need to do going forward as a community interested in improving performance management of primary healthcare systems? So without further ado, I'd like to introduce you to our first presenter, Dr. Wolfgang Munar. Dr. Wolfgang Munar is the Program Director for the Global DRPH Program and an Associate Professor at the Milken Institute School of Public Health at the George Washington University in the US. Dr. Munar has been engaged in global health practice and research in maternal, neonatal, and child health, in HIV/AIDS, malaria, and tuberculosis in Latin America, the Caribbean, Sub-Saharan Africa, and Central and South Asia. He has experience and a keen interest in performance improvement in primary healthcare systems. He has an active global health research program in India, the Honduras, El Salvador, and Kenya. Dr. Munar, over to you. After Dr. Munar completes his presentation, we'll have a 5-minute Q&A, as Manushi said. Thank you.
Thank you very much. Let me get this ready. Okay, thank you everybody for attending. As Dr. Ved said, I am an associate professor of health systems research at the Milken Institute School of Public Health in Washington, DC. I'm very glad to see some of my doctoral students in the audience. In today's webinar, I am going to focus in the presentation on ongoing research into gaps in evidence in performance management systems in primary healthcare in low and middle income countries, and particularly today on identifying some of the implications from those studies about the type of research agenda that we collectively should consider. This is a definition that we are using in my team to characterize what performance management is. And I have to highlight here that the focus of or the framing behind this is about organizations and systems, not about individuals, which is the focus of essentially research on human resource management. This is not a new field. It's been going on. It's been around for a while, and it is a particularly fertile field in two areas. In practice, it's extremely well developed in public management and in business in general, in the practice of these two areas, but it also has a very rich research tradition. It's multidisciplinary. It has a strong focus on organizational behavior, institutional sociology, economics, political science. I mean, many, many different fields. The field, as it has evolved, has created what we are calling two different approaches that are part of a continuum, okay? They are not supposed to be polarizing. On one end, you have the most frequent use or approach, which is what we call directive, which is about managers trying to exert control over the actors in the system, which is why we call it directive. They are trying to influence actors' behaviors. And by actors, I not only refer to workers. It's going to be other managers, there's going to be principals involved, etc. The other approach, which is more recent, we call enabling, and we're of course not the only ones who call it that way. This is an approach where we see actors in any system as having individual and collective agency, which means that they are capable of making choices and decisions. And in this approach, we see system actors as stewards of the system. They're empowered to use their agency to make decisions. So in order for such managerial approaches to work, managers have to trust actors. Now, after 40 years of research and practice, we have learned that when these systems are effective, which is not often the case, they sustain through time and they actually contribute to health outcomes if and when these management systems trigger continuous adaptive cycles of improvement and learning. Improvement in this language is what we in clinical care and in health services research call quality improvement. Learning is what in organizational science we refer to as second loop learning, which means that an entire system, organizations, and all the collective members of the system have the capacity to adapt and absorb new knowledge. And the more they learn to improve, the faster they can improve the system. Finally, it's very important to note that when we talk about performance management, there's a tendency in the literature to talk about individual level change. We believe that's obviously fundamental, it's the DNA of change, but we're more interested in better understanding how the micro level of individuals connects to the meso level of organizations or interpersonal relations, and critically to the collective or social systems in which the health system is embedded. That's a macro level. We're gonna go through this a little bit in some examples. Now, before we get into the actual research, we wanted to make sure that we could frame this in a way that we at least try to get a common language so we can make sense of what I will be describing briefly. So this is a very stylized view of a performance management cycle. It starts with the system's priorities and goals, which in our case could be, I don't know, universality, comprehensive care, continuity of care, effective coverage, equitable access, all of the above other goals or priorities. It follows with incentives that are driving the behavior of individuals. And more often than not, these incentives are intrinsic. Are the reasons or the motivation for which people join public service or medicine or nursing or community health work. But they also include extrinsic incentives such as salary, and now that is very fashionable in global health, pay for performance and the external incentives. Then there's also, in every system under different names, there are mechanisms for measuring performance, usually on an ongoing basis, and more often than not for accountability purposes, but also for improvement, as we will see in the example in the next presentation. There's also different types of feedback. Actors in the system via supervision, via other mechanisms, reporting, etc., appraisals, receive feedback about performance of the facility, for instance. And as you all know, we human beings are cognitively impaired to make sense of raw data. So there's also got to be a process of transforming raw data into information, so we as human beings can imagine future action based on that data. Now, also there's a process of planning for future action. This is one of the areas that is least understood in the literature, how people make these choices and decisions, how teams coalesce or not to imagine future scenarios and then implementing them. And finally, out of this action, there's some kind of outcomes that may or may not trigger changes in priorities and goals, which in our case in primary care could be, we can decide to change the way we deliver certain services, stop doing certain actions, or actually create new services. So based on a research commissioned by Ariadne Labs and the Bill and Melinda Gates Foundation a couple of years ago, our team at the Milken Institute School of Public Health, jointly with the International Initiative for Impact Evaluation, better known as 3IE, and in collaboration with the Salud Mesoamerica Initiative, we built an evidence gap map of primary healthcare systems in low and middle income countries. This is the approach we used. We didn't invent a methodology, but since we were working with 3IE, we used their methodological approach. We published the protocol. In general, we built, since the very beginning, a multidisciplinary framework informed by the rich evidence and theories that already have been developed in the last 40 years of practice and research in public management, in health services, in organizational science, and in behavioral sciences. We decided to do this as a very broad evidence gap map. We wanted to be as inclusive as possible, but we limited our study on supply side interventions that could happen at the provider level, at the facility level, and at broader social levels. And finally, we also went very broad in the study of outcomes, making sure that we would capture this idea that change is multi-level. So we looked at outcomes at the individual, organizational, health system, and populational levels. I'm going to go relatively quickly through these next few slides because we can discuss more the methods. Obviously, we will make available all papers, but in general, you can see here the types of studies that we included and excluded, which gives you a sense of which type of phenomena we could capture or not. Second, the broad type of interventions that we used, that we mapped, and the types of outcomes, the study designs, which included systematic reviews and impact evaluations, and the time frame and language. Here you can see in more detail this broad scope or inclusive approach to performance management interventions, and you see the ones that are called implementation strategies that operate at the provider level, the implementation strategies that operate at the facility or organizational level, accountability arrangements, of which we will hear a lot more in the next presentation, and financial arrangements that, as I said, are very fashionable, as all of you know. Then in terms of outcomes, we also went at the provider and manager level, we went at the organizational level, at the patient level, population level, and social and equity outcomes. Again, we can discuss this later, but I just want you to know that we were not reinventing the wheel. This is all based on the Cochrane's collaboration, Norwegian satellite work on the organization and delivery of care. These are the same indicators of interventions and outcomes that are conventionally used in health services research when one does, for instance, a systematic review. Now, our search of the various academic databases identified more than 38,000 studies since 2000. After multiple iterations, we reduced the sample to 137 impact evaluations and 18 systematic reviews. The systematic reviews were assessed in detail. The impact evaluations were not assessed for quality, but data was abstracted from them to explore which interventions, which type of studies, which types of outcomes were studied and what were their findings. So we organized this in an evidence gap map. I'll show you the actual map later and the address so you can go and play with it. What you see in the top row are the outcomes, and what you see in the column to the left are the interventions. And the circles identify larger circles, the larger number of studies. In blue are protocols, in red are systematic reviews, and I don't know what's the other one, sorry, I forget now. So as a summary, we found that the largest number of impact evaluations and systematic reviews, i.e. clusters of evidence, happened in-service training and to some extent pay for performance. And that most of the outcomes that were studied in these last 20-something years were about providers' knowledge and patient health outcomes. So these outcomes are individual level, as you can see. Now, in general, when you look at other evidence gap maps, you see a lot of boxes full of evidence. This one has a lot of blank spaces. So in general, we qualify this evidence gap map as sparse. There's not a lot of evidence, and there are areas where there's absolute intervention gaps. So there are no studies, for instance, or there were no studies about many of these accountability arrangements and some of the implementation strategies beyond training. As you know, we all love to talk about continuous quality improvement, but until recently, there were not many studies, actually experimental designs or quasi-experimental. We were very happy when we saw Margaret Crooks and teams work on the Lancet series on quality, but there's still a lot more to be done in this area. And of course, that's only one example of an implementation strategy. The other important point is that there were also huge gaps in outcomes. In particular, there's almost nothing about organizational behaviors, such as particularly the behavior of teams around quality of care or patient satisfaction. Or this is a huge area, okay? Adherence or collective adherence to clinical guidance, etc. There's little to nothing at the social and equity, in terms of social and equity outcomes. This was very scary for all of us because there's so many in the language of primary healthcare around, for instance, community participation, community voice, horizontal accountability, social accountability, yet it wasn't measured. And as I showed before, it wasn't measured as an outcome because there are very few, if any, studies or impact evaluations of these kinds of interventions. And perhaps the most concerning finding was that there was almost no report of negative or unintended outcomes. This is not something that only happens in this field. It's a problem in impact evaluation that needs to be addressed in a more structural manner. Now, beyond the scarcity of evidence that I already mentioned, which is on the left side of these three boxes. There's a couple of additional implications or findings that we think are very important for the future, for the design of future research agendas, and actually for policy implementation and analysis. First, there's this tendency of most impact evaluations being poorly theorized, essentially not having a program theory, not setting a very clear understanding of the context, the resources that were at play, the implementation approaches, and then a lot of simplistic, linear theories of change where some intervention like training or something like that would kind of magically produce changes in the health system or changes in population health. And what we learned is that actually these are very complex processes, like Dr. Ved said very clearly in the beginning, that there are a lot, like I said, also about human agency and interactions, and therefore you cannot theorize them simply using conventional single theories and using single study designs. We need collectively to try to better understand the assumptions that are made about how performance management can change proximal, distal, intermediate outcomes that are about human behavior, organizational behavior, about trust, about leadership, and that are a long way before, that need to be produced a long way before actual health changes can be evident. It's also appalling, in my opinion, that we have done very little service or used or recognized even the existence of a huge literature on social science, from sociology to actually old-fashioned implementation research, policy studies, evaluation studies, etc., that could be used to better frame the theoretical causal chains that would explain how performance management change organizational systems and health systems. Very limited use of mixed methods, and we actually found some very high quality studies that use mixed methods, but they were the exception to the rule. We think it's also very important to notice that we need to stop thinking as a collective of practitioners and researchers about processes of change, improvement, quality improvement, and health systems performance as changes at the individual level. These are changes at multiple levels, and our knowledge about such complex process of change is very limited. And finally, perhaps two important areas of challenge in the literature is how little we understand about how these interventions work or not and why. We need causal explanations. Policymakers need to understand when things work, why do they work or not, if all of these important interventions are going to be adopted and adapted widely. And obviously, a call for action immediately for me is the lack of measurement of outcomes about harm and equity, which were so poorly represented in this literature. And as you know, all these systems have negative unintended side effects that need to be looked at. For instance, in the case of performance-based financing or pay for performance, the use of gaming and other techniques, falsification of data, etc., that have been widely demonstrated in high-income countries and all over the world. Now, to close, I think that's very important, and this is not just superficial call for action. I really want to tell you, I really believe that we need to ask commissioners of research to stop funding these very vertical, fragmented approaches to evaluation of performance management. We also need to look for truly collaborative and participatory research that is done in low and middle income countries. This cannot be, I don't know, parachuting in and out of a health system. It has to be done in the context where change is happening or is about to happen or has already happened and succeeded or failed. Second, back to, then this is kind of my mantra, my students know this very well, we need to think outside of the box of public health and health services research and go to social science and go to other sciences that have a lot to offer to understand organizational and systems change. We have to drop the linear models or theories of change and look at more nuanced and yes, approaches that perhaps consider complexity theories and systems thinking. We need to characterize change at multiple levels. And finally, we need to ask evaluation questions that are not about did it work or what worked, but about how did it work or not, why, and for whom. If you guys, when you receive this deck, you simply go into this link and it's going to take you to the 3IE website where you can see the entire map and it's iterative. You can play with it. You can go to the studies. There's a lot of stuff that you can do there. And by the way, look at all of the other maps that they have there. I'm also going to share with you some of these, some of the literature that I have used. Okay, thank you very much. Over to you, Dr. Ved.
Thank you very much, Dr. Munar. What a pleasure to hear you. And I think what I take away loud and clear is the messages in your last slides. Looking at multidisciplinary approaches, using methods such as realist evaluation, because I think one of the challenges we all are struggling with is how do you convert global operational strategies into locally contextualized strategies? And that's what I think practitioners and program managers and researchers are really grappling with. So are there any questions, Manushi?
Not yet, but I encourage everybody to ask questions.
Or we can continue and then open the discussion after Diego's presentation.
I think so. So what I'm going to do is to request Diego. I will first introduce Diego and then request him to make a presentation. Following which, I'd also like to have the chair of the steering committee of the Primary Health Care Research Consortium, Dr. Bob Mash, who's joined us today as well. So Diego Rios-Zertuche is a monitoring and evaluation officer for the Salud Mesoamerica Initiative and the Regional Malaria Elimination Initiative at the Inter-American Development Bank. He oversees large-scale performance measurements for the results-based financing model of each initiative. His interest is in improving metrics to measure healthcare quality and in the use of data for managerial decision-making and quality improvement. He has a lot of experience in supporting program design and development and quality improvement projects with government and non-governmental organizations across the United States, Latin America, and India. He is originally from Mexico City and would like us all to know that it turns purple in the spring when jacaranda trees flower. What a beautiful image. Thank you very much, Diego, and over to you.
Well, thank you so much. Just let me start putting the slide. There you go. Okay, thank you so much for that beautiful introduction. Hello, everyone. Good evening, good morning, and good afternoon. I'm presenting today on behalf of Emi Riarte, who unfortunately, due to a personal emergency, could not join us today. I think many of the points that Wolfgang raised resonate with our work. So I hope my presentation will leave you with a couple of things to reflect after my presentation. So let's start by thinking, looking back into 2012, we had a challenge. So how could we support the ministries of health in 8 countries in Mesoamerica? And Mesoamerica is the region between all the way from Mexico to Panama in Central America. How could we expand access, coverage, and healthcare quality for the poorest women and children in the region? Salud Mesoamerica is a public-private partnership comprising 8 countries, all the way here from Mexico. From Mexico to Panama in Central America. The Bill and Melinda Gates Foundation, the Carlos Slim Foundation, the Government of Canada, and the Inter-American Development Bank as the general administration of the fund. And just for your reference, in most of Latin America, the ministries of health are the main healthcare provider for the poor. This initiative is implemented by ministries of health in each country and their healthcare networks. So, okay. The design of Salud Mesoamerica is based on 5 core elements. First, collective impact. That means having one aim and one single system of metrics. A results-based financing model with outcome-levered targets, incentivized and verified externally. SMI finances a cost-effective and promissory package of interventions. Technical assistance is demand-driven with a systemic instead of programmatic approach, and is based on iterative approaches to test, adjust, and learn quickly. And this is key, adjusting and learning quickly. Going back to what Wolfgang mentioned as the second loop learning. We also support countries to plan for scalability, institutionalization, and sustainability of all interventions. So these are the core elements of the initiative. The heart of the program is the results-based financing model. Ministries of Health and the Inter-American Development Bank agree on 10 outcome indicators and targets along the continuum of care, depending on the context. Half of the country program is funded by donation funding, and the other half with national funding. So basically, the initiative puts half of the money in for implementation of the program, and the other half is brought in by each country government. And then if the externally verified targets are met, countries receive a performance award. And this award is equivalent to 50% of the money that the governments initially invested. And it can be used freely within the health sector. So those are the high-level elements, but how does SMI actually work? Every health system has a number of inputs that go into a transformation process through health system processes. This is what we call the black box on how the system engine actually works to produce a certain level of performance, because many countries with similar inputs end up producing different levels of performance. Finally, they produce healthcare quality and coverage that ends up creating a certain level of population health. So SMI works through catalytic elements that work directly on this engine that is transforming how the health system processes operate, improving management practices, motivating leaders and workers, designing new processes and flows and procedures. And we work both at the individual and interpersonal level, as well as at the collective and inter-organizational level. Many organizations cut corners, and they build a separate structure that may end up increasing quality and coverage for some time, but once the organization leaves, the system collapses because there's no more funding to continue financing that parallel system. In case of Salud Mesoamerica, we are working with those same people and those same ministries of health and that same health infrastructure that was already there. So we are hoping that once we leave, at least part of what we brought in will remain. So has this approach actually paid back? That's I think, a big question. Well, external surveys conducted by the Institute for Health Metrics and Evaluation at the University of Washington showed large improvements in coverage and quality indicator across all of the continuum of care. And the improvements have been many times faster than what is usually observed within the same time frame. So for example, here in 5 years, we have about 15 percentage points improvement of institutional deliveries, a huge increase in family planning in El Salvador, the uptake of the MMR vaccination in Nicaragua, almost 25 percentage points. These are things that normally within 5 years you observe 5 percentage point changes. So seeing these really motivates us. Here's another example. After 5 years of work in El Salvador, the proportion of women that gave birth in a health facility, that is the blue line, this is the intervention areas in SMI, increased from 86% to 98%. And if we compare this with the national level, which is the green line, the green line, you can see that the performance of intervention areas not only closed the gap, but surpassed the national average. And let me tell you that this particular indicator is a reflection on how the primary health teams are performing, because it was the doctors, nurses, community health workers at the primary health centers who motivated women to get antenatal care, to write a birth plan, which finally led them to seek a facility to give birth. So these are really encouraging results. And this is not something that we saw in only one country. In Honduras, in facility delivery by qualified staff increased from 71% to 90% in SMI intervention areas. And our impact evaluations show that we can attribute 12 percentage points directly to the work of SMI. In Costa Rica, we work in the implementation of a very ambitious multi-sector strategy to reduce adolescent pregnancy. Adolescent pregnancies, as you know, are a big problem worldwide, almost in every country. So this strategy created a support network for at-risk adolescents, giving them access to school support, healthcare, counseling, and childcare. A quasi-experimental impact evaluation was conducted using birth records to compare the 44 poorest districts with the 341 districts with highest social development in Costa Rica. So in the first phase of SMI, we found no effects. That was expected because all the work involved things such as designing specialized software to interconnect all agencies, creating competencies for staff, creating basically improving the health system to be ready to improve their services. During the second phase, which was the actual full-scale implementation of the program, we found, as you can see here, and it's very light, as you can see, the trend not only reduced nationwide, but it also caught up very quickly with the districts with the highest social development. So the adolescent fertility rate decreased 11.4% relative to the pre-intervention average, with greatest reductions in the group of adolescents between 10 and 14 years old. And these results are robust if we modify the comparison group and use others to compare. So we've found after these 10 years of work in Salud Mesoamerica, we've learned a few things about what has worked to improve primary healthcare. First of all, very intense efforts to collect data through external and ministry-led measurements. So it's not only external measurements, but also ministry-led measurements. Secondly, which is connected to the big data collection efforts, the measuring to act, not to report or study. Then constructive destruction is necessary. It's very important to know when to pivot and change course. Accountability mechanisms, not only top down, but also bottom up. So doctors and nurses should be in a position to ask their leaders, where's my stuff? Why don't I have the things I need to do my work? We have rapid learning cycles based on that data. Quality data has to be available often and analyzed immediately. So the data is just for decision making. We need quality data, and once we have that data, we need to use it to make decisions. We have an increased focus on subnational and local levels with information, plans, monitoring, and competencies. Many interventions get stuck in the middle. These regional managers at regional levels, at district levels, are sometimes ignored. And therefore, we end up with misunderstood objectives, lack of supervision, conflicting priorities. So it's vital to include them in all the planning and to make them owners of the interventions. And finally, coaching and mentoring as a way to support operations and monitor progress. So supporting people do their work is part of our intervention and is what helps us monitor the program, know that we're doing well, and get to the place we want to get. And to close with just a few of our challenges, because we've seen many in all of these experience. The first question is vertical interventions versus system-wide approaches. How to choose when it's right to follow one model and when it's right to follow the other. A second challenge is the COVID-19 pandemic that has really brought havoc to the region. The region is also one of the regions with rising number of cases around the world. And in many settings, the primary healthcare system has become paralyzed. So the big question is the pandemic a test for resilience, or is it gonna be a big setback for our work? Then another question is, how can we support countries make quality improvement part of their routine? And this is especially important in primary healthcare, and especially when we go to smaller clinics. How can we help those smaller clinics work with others so that they learn with one another and they can learn to improve by themselves? How can we create or bring the highly needed competencies to the regional and local levels? Management expertise, analytical competencies. These are things that are lacking in these middle levels, and we need to be able to bring them there. And finally, how can we make sure that incentives are aligned between all levels of the system? This is a big challenge because maintaining the incentives at the political level and at the local level is very difficult, and we need everyone to be working towards the same aim. So thank you so much for your time and attention, and I'll be happy to answer any questions.
Thank you very much, Diego. I really like the way you were able to position within a macro framework of results-based financing, this really focused attention on coaching, mentoring, on subnational focus and processes like PDIA And that would be really interesting to hear, and also to hear that you managed to scale up some of these approaches. So thank you very much. What I'm going to do now is request Dr. Bob Mash. Bob, are you there? Yes.
Yes. Yeah.
Dr. Bob Mash is the chair of the steering committee of the Primary Healthcare Research Consortium, and I'd request him to make a few interventions before we start addressing the Q&A, the questions in the Q&A box. And meanwhile, I'd encourage attendees to please start putting in their questions. Thank you, Bob. Over to you.
Okay, no, sure. So thanks to Wolfgang and Diego. I suppose I've got to, maybe I can make a few comments and the sort of questions to stimulate some further discussion. I'm sitting in Cape Town in South Africa, by the way. So my background is as a family physician, a clinician in the health system. And a few comments that I would have. The one thing I think which I would agree with you on is that, I mean, we've seen in our context, and I think a lot of the African countries, that some programs have a lot of data to improve performance, like HIV programs in South Africa are sort of all singing and dancing, in terms of electronic data and feedback on performance. But that right next to it, there's a complete absence of any information, like, for example, with care for diabetes or some of these other programs that don't get the same attention. So I totally agree with you that somehow we have to get away from these sort of vertical inequality in a way, and an inequity in performance management in a way between diseases and programs. But then it becomes extremely complex, doesn't it? How does one actually create this kind of more integrated, comprehensive performance management system that goes across the burden of disease, that is comprehensive, without being completely overwhelming in terms of its demands to collect data and process it? So I suppose that would be, that's a question for you guys. So if we want to move to a more integrated, comprehensive performance management system based on evidence and data, how do we do it in a way that is kind of manageable? Is kind of, you can get your head around it at a sort of district or facility level, or even regional level, without, because like if you go, often when you go to policymakers and at a national level, you can all sit in a workshop and come up with 500 indicators that cover everything. But of course, it's not possible to actually really measure that and provide that level of detail accurately and so on. So that'd be my one question. My other reflection would be that one of our experiences of doing sort of very small scale quality improvement work in lower middle income countries in the sort of African region is that actually very small interventions lead to quite big short-term improvements in quality. You don't actually necessarily need to do much to improve quality. And it seems like we're starting from a very low base and often with the basics missing. And so in some ways, I've often quite shocked at how quality improves with almost no real intervention. I mean, very minimal intervention. And how do we leverage that? And because a lot of what you're talking about seems highly complex, highly sophisticated, huge kind of national level machinery. But often I wonder whether in low and middle income countries at the sort of facility level, one could actually do quite simple things. If they could be maintained, they would actually lead to quite impressive quality. I see Rajani has come back on, so I should probably be quiet. One final thought for you.
Go ahead. I just
two final thoughts actually. One question for Wolfgang. So from that amazing evidence gap map, if you had to lift out 1, 2, or 3 really kind of feasible and important research questions to look at next, what would they be? And my question to Diego is, you kind of presented to us big successes, I mean, really impressive successes in the Central American region. Wolfgang presented to us, in a way, a framework for making sense of performance management. How would you sort of map what you've learned on how to do it onto Wolfgang's kind of framework, you know, the different levels, the cycle that he presented, and where was your learning in that framework? Okay, there we go. I shall leave you to discuss some of those things.
Thank you very much, Bob. You know what I'd like to do first, if you guys have noted down Bob's questions, I'll go to the Q&A box and call out some of the questions. And if people haven't specified to whom they're asking this question, I'd like you both to take a go at it, okay? So there's a couple of questions on human resources. One asking about how much do you think a non-physician health worker being a local member of the community influence delivery of primary health care? And a second and related question is, can geographical quotas in recruitment, especially in remote and difficult areas, help retention of health workers? So I'll just go with that, both of you, and then go to the next question after we're done.
Who goes first?
Wolfgang?
Okay, thank you for the questions. So the answer to the first question about community health workers, which is a topic that is very dear to my heart, and to Rajani also, is that it really depends on context. I will tell you from my own empirical evidence that, for instance, in a study in El Salvador, which Diego mentioned earlier today, I found community health workers that were democratic, equal members of multi-professional teams. And the team included always a doctor and a nurse, sometimes others. But the entire success of the outreach enterprise of these teams, primary healthcare teams, hinged upon the ability of the community health worker to mobilize the local communities, to have a direct contact with the village, and actually the fact that they all lived in the same geographical area, doctors, nurses, and community health workers, made for a fascinating case of closeness to community and this unusual reversion of roles and responsibilities where doctors are actually team members, but when they go to outreach, it is the team leader, actually the community health worker that leads the team. They are the ones who organize the operational aspects, etc. So all of this is an adaptation of roles and responsibilities to the specific context and can be very, very successful. It's a form of disruptive behavior. It can only happen if the team puts the community's goals and priorities and their health above their own individual, oh, I'm a doctor, I'm better, I know more. And you know, that's not going to happen everywhere. In the case that you mentioned in Bihar, the study, by the way, my colleague Syed Wahid is in the call, so if he wants to answer in writing in the chat or something. In that case, and as Rajani knows very well, the context doesn't help because of the way that the ASHA workers were selected and are selected, and the lack of responsiveness and support from the formal health system, the lack of this embrace that we see in El Salvador and in Honduras of the community health worker as an, you know, relevant, truly important member of the team, it doesn't allow for this kind of, you know, creative disruption as we saw in El Salvador and other places. It doesn't matter. It doesn't mean that it cannot happen. But there's a lot that needs to be done before, you know, volunteers and ASHA workers, for instance, can become the kind of influential member. Now, I will tell you from my own data, the level of influence, informal influence, that these wonderful women have on their local communities is outstanding. The level of empowerment they have attained as women that now can go out and work, women with low levels of education, of lower caste, etc. That wouldn't have happened if the Rural Health Mission in India hadn't set the stage for the creation of the ASHA program. So Let's give it more time, but I think this is going to need a lot more interventions. You can look at other examples. And finally, in the case of geographical quotas, I don't know. I remember when I was young in government in Colombia that I promoted this, but I was the vice minister of health, but my boss, the minister, said, who was an economist, said, are you crazy? This is a disruption. This will never work. We cannot force people to go. So anywhere they don't want to go. I agree with this now. I would only mention the case of El Salvador again, where the reform of the health system created an institutionalized way in which doctors, nurses, and all the community staff have to live in the community where they serve. And they're paid very well. And that makes a huge difference. Over to Diego.
Diego.
Thank you, Wolfgang. So these are great questions. I think we may need to set up another webinar to answer some of them because they are definitely not simple. But let me start with some of them. In terms of, Bob, your questions, I think they are great. In terms of how can we make sense of these comprehensive performance management systems that are not overwhelming. I'm a monitoring and evaluation officer, so I like data. So I actually do favor aggregating data, but with a big but, and that's to keep it meaningful. So I'm against indexes that basically put everything in a bucket, mix it, and then you come out with a number that you don't know what it means. So I think it's important that whenever data is aggregated, you can, let's say, open the box, and that data is still meaningful for mid-level managers, and then for health facility managers and practitioners. And I think that's where the challenge is. How can you create indicators that stay meaningful regardless on your level of aggregation? So the other issue that you mentioned was small interventions leading to large improvements in quality. And that we talked about all of this complexity, but how can you really, do we have examples of these small changes that bring huge improvements? And we do. And it's actually incredibly simple how we found them. So for example, in El Salvador, after visiting multiple health facilities, we found that one of the doctors in one of the small health facilities, you know, we're talking about one doctor, one nurse, and maybe a couple community health workers. They created a screening tool to screen all women in reproductive age and ask them if they were using a family planning method, if they wanted to get pregnant, or if they had missed a period. And this very simple tool we've scaled it up throughout the region, and it's an excellent tool to promote use of family planning methods, because you very quickly find women that are not using methods and don't want to get pregnant. And it's also a great tool to catch pregnancies early. So it's a very simple tool. It was created in a local context by a small clinic, and we were able to bring this learning to the entire region, not even just to El Salvador, but now it's being used in all countries in the region. So that's one of the examples of small things that can really help make big improvements. In terms of the geographical quotas and recruitment to help recruit health workers, and I think I'm with Wolfgang that this is an extremely challenging topic. Many things have been tried for this. scholarships to train local doctors and nurses. That hasn't always worked because first of all, it takes a lot of time. And then once you train those doctors and nurses, even though they are from a local area, they don't always want to stay there and go back to these places because they don't have the same opportunities that they would have elsewhere. There are salary incentives, and I can tell you a lot on how that has gone bad. I won't mention countries by name, but there are many bad experiences. They have also tried temporal appointments, and they work for certain very specific things, but they don't work for many others that really need people to be there. So there's really no silver bullet. And I would say that perhaps we have to start by making sure that the health systems don't fail their workers. Because many times it's really the disappointment what pulls people away, that they don't have the things they need to provide care. No one is supporting them. So they have no opportunities and no reason to stay providing care where they are because they just can't do it in the way the health system is operating. Thank you.
Thank you, Diego. I actually will give you a little bit of pause, although there is one very specific question, but I'll come back to you later. Let me go now to Wolfgang. Wolfgang, a couple of questions for you. One, does academia or universities have a role constructing or advocating for primary care research development? And is it necessary to create specific academic units to improve the evidence we need for primary health care?
Thank you. I'm going to take that question and address the ones that Bob asked because I completely forgot. So I don't know that there is a generic answer for this very interesting question. And of course, I am very biased. I would say that there is need for more of these networks of mixed networks that combine practitioners, policymakers, and researchers. And I really mean what I preach. It is, if we keep isolating research in the nice environment of the university, or not so nice, it doesn't really matter, but isolating it over there, instead of embedding it where the action is taking place, then that is not going to do us much service. We're going to continue to be using different languages. We're not going to be communicating to each other. We're not going to be aligning in our interests, in our goals, etc. So I'm a big believer, and if anything, I would advocate for is collaborative, participatory research with policymakers. I'm a policy person, so I would prefer to tend to work with district level or state level or ministry level folks, but others are better equipped than me, for instance, to work with practitioners, with community health workers, etc. And we need work at all these levels. The second point perhaps that I would make is there is not a field, in my opinion, that we should call primary healthcare unless it's a medical field, which is completely okay. But from a research perspective, if anything, from the evidence that we discussed earlier, this is a really multidisciplinary endeavor. So most likely not a single researcher, not a single university, let alone a department, will be able to cover all this vast knowledge, which is again why networking arrangements seem to be optimal for this sort of thing. And then perhaps the final reflection is, what are you trying to achieve? And I wouldn't launch a network just for the heck of it, but you need to be driven by some kind of goals. Of course, this betrays my own internal approach to performance. I'm motivated by, achievement of a goal or a set of goals. And this allows me then to go back to Bob's question. Of course, Bob, I've been thinking about this for a long time, and I struggle with, if I were, to be given the opportunity of developing an agenda, what would it look like? So I'm not sure I'm going to be completely, you're going to like my question entirely, but let me put it out there. I'm actually advocating for, first of all, a change in methods and a change in questions. And Rajani put it very well. She translated my plea about asking how or how not and why and who benefits as a realist evaluation framing. But in general, I would say that you can also use other epistemologies, not necessarily applied critical realism. There's many others. And I would welcome that approach, but I do not want yet another RCT that tells me, oh, how wonderful this is, but disregards context and all this richness about the explanatory richness about how things happen or not. So this deserves a big discussion. Obviously, it's happening. The meeting where I met Rajani a few years ago actually was an attempt by Ariadne Labs to bring together these different groups. It was fascinating. Number two, so the question is not, not a research question, but first is a framing of the approaches, the methods, and a reflection on what type of things are we trying to address. And that then leads to perhaps other considerations. Now, based on what I have uncovered and trying to look at multi-level phenomena, and your own question about data and data inundation or flood of data, however you call it, and the inability of our brains to deal with so much data, etc. I think there are two big questions that cut across multiple levels in the system that we should really address. And I acknowledge fully, openly my bias because I am working on these two or trying to. So, but number one is motivation. Motivation, which could be work motivation, is something that even in industrialized nations, it's one of the few areas where there is no disagreement among researchers. That motivation drives intrinsically the behavior of folks. And we need to understand the positive and negative effects of widely used incentives on intrinsic motivation of workers. But I'm more interested in collectives, in groups, in teams, because as we all know, healthcare and primary healthcare in particular is mostly delivered in diets or in small groups. So how do motivation works, the intrinsic aspects of it and the extrinsic aspects of it would address many of the HR and performance management questions at the level of groups and individuals. And the second is the one, Bob, you're asking. It's about the uses of information. I think, and this is another area where there's some degree of agreement, but a lot of contestation, is it really about producing a whole bunch of pieces of data? I don't think so. I think that we need to rethink what performance is, and I believe performance emerges. It's not something that exists. So your exam, therefore, we are always measuring performance through proxies, and we need to acknowledge that. And one of the things that I believe Mesoamerica has contributed to this bigger discussion is that it's not really about huge dashboards and scorecards. It's about, yes, you can measure many things. But in the end, if you want to incentivize, softly incentivize performance by increasing alignment of individual and team motivation to system goals, you need to start thinking about smaller sets of indicators and targets, priorities, rationing the number and the scope of indicators that are being used by managers, again, to incentivize, to increase alignment, to do feedback, et cetera, et cetera, et cetera. It's not about creating these huge dashboards, et cetera. Now, on the other hand, using Diego's example and your own question, Bob, if you let teams or groups decide what is the data that they need and support them in collecting it quickly and acting upon it, that has been proven time and time again to be at the molecular level, the drivers of quality improvement. So I think we should not mandate this. We should let teams decide. So if in your context is about diabetes and hypertension, then there's no need to be spending time on other things that are not priority. And I'm going to close with a little bit of a plug for my own way of thinking about health systems, which is about complexity theory. Bob, one of the main characteristics of complex systems is exactly the way you described is beautiful, which is a little disruption in one part of the system, which could be this little group of folks who meet every week to look at data and plan immediate action, i.e. quality improvement, can lead to huge changes. We need to better understand how that happens, okay? There's no guarantee in a complex system that first, this little change will spread widely, and more importantly, it rarely, if ever, sustains through time. So we need to go back to thinking, okay, how can this little bit of a change, which is self-organized, which can spread, how can, let's say, a change agency or any support agency, a district officer, a state level ministry, ensure that this facilitates the spread of such behaviors? And there's a huge research question there around again, it's going back to networks and dissemination efforts, etc. Less directive, more helping it happen, which tends to be, again, my bias. And we don't really know a lot about it. There's a lot of evidence out there. And finally, in terms of research, Bob's question, but there's an anonymous attendee who asked the question. I'm not saying that we shouldn't do impact evaluations. Oh no, the opposite. I'm just saying that we need impact evaluations that go beyond the conventional question of what were the effects that only measure positive effects into measuring all the richness of outcomes, and also addressing how did it happen, why, or why didn't it happen. And then with this, I think over to Rajani.
Thanks, Wolfgang. Diego, this is for you. How does the private healthcare system help or hurt the learning primary healthcare system? And that's really, I think, important. It's the big elephant in the room that none of us consider, because all of today's presentations, we have been talking about government health systems. How do you make the lessons from your research-based intervention stick in the fundamentally weak health systems of the Mesoamerican region? I think that's a very important point. I noticed that the WHO's primary healthcare operational strategy also emphasizes quite a bit on public-private partnerships, recognizing that that's the way, whereas many countries have chosen to do primary healthcare completely through government-funded public health systems. So Diego, we'd be interested to hear your response.
Thank you. That's a very interesting question. And I think here we can totally start crossing in ideology, because this is probably a very contested topic. In our experience, the private system, at least in the areas where we work, is almost non-existent. The way we see the private system is more through very small pharmacies. And I think the challenge there is to work with pharmacies to prevent some of the very common problems, such as self-medication and all of these things that bring a lot of health problems that are unintentional. So I would keep my answer short just by saying that it's not an area that we've worked extensively with. We don't see the private sector as a competitor, or and we also don't ignore it. We see a strong need for the public sector to perform better, because that's the main provider in these areas.
Thank you, Diego. I agree with you. It's a completely ideological perspective, especially primary healthcare, public sector funding. And, given COVID, I think it's brought home to us the fact that certainly subjects like communicable diseases, outbreaks, pandemics, where there are positive externalities, lie completely within the role of government. And I also see this point about private health sector being non-existent in remote and rural and difficult areas, or in slums, or in underserved areas, even in urban areas, you know. So the emphasis on private sector really, and it also depends upon a very strong regulatory system. In government systems, one can introduce performance management approaches, also take them to scale because government has that leverage. But in private sector, unless you have very strong regulatory systems, which is not the case in many LMICs, it would be difficult to see how you engage private sector in primary healthcare. And having said that, I think also in urban areas, there may be in some parts of the world a case for contracting with private sector, maybe just for service delivery, but that's a different topic for another day. Bob, do you have any other reflections? Wolfgang, would you like to speak to the issue of private sector? But of course, after Bob.
I suppose, yes, thank you for your answers. My reflections, again, on the private sector issue. I mean, certainly in South Africa, we've had a whole investigation of the private sector. And one of the interesting things seemed to be that there's actually very little collection of data regarding quality, actually. Interest, a lot of data about other things like money, but not so much about the quality of care, although we often assume that somehow that the quality of care is better. My one other question or reflection, I suppose, was I did pick up on one of your slides, this idea of the need for competency at a local level in order to do performance management and to improve quality. And I'm sort of thinking about, well, what does that really mean? We know that in low and middle income countries, primary healthcare teams often do mainly consist of community health workers, nurses who maybe haven't been trained in this sort of thinking. Like in Rwanda, for example, at one point, most of the nurses were trained in high school. What does that really mean? Obviously, I'm also biased, Wolfgang, because I mean, one of the arguments that I'm making in South Africa is that primary healthcare teams should include a primary care doctor or even a family physician who has had some training, in, handling data, making sense of data, planning, with a team, not in isolation from a team. So what does that really mean, do you think? What is the implication for primary healthcare teams, this idea of you need to have competency at the local level?
Can I start?
Yep, Wolfgang.
Well, absolutely spot on, Bob. And I think it's important to acknowledge that in the case of the 8 countries that Mesoamerica covers, there are doctors in every primary care system, which, as we know, is not the case in every country. Second, the presence and solidity of the work of nurses is also, it's being developed now for decades, is very important. And finally, in many of these countries, community health workers have been around since the 60s, and in almost all cases, as far as I know, they are employees. So it's not the same situation as, so it's more like Ethiopia than, let's say, Bihar. That's kind of, again, that's why context matters so much. You can all imagine the amount of resources, cognitives and social, that these individuals bring to their work. And when they are operating in teams, they are self-assembled in certain ways, etc. Second, there is a huge wave of decentralization in the health sector that started in Latin America in the 80s. And all these countries have gone through this. So again, this has led to the emergence of certain behaviors and practices that in public policy are normal there that might not be normal in other countries. For instance, like in El Salvador, giving these primary healthcare teams kind of the status of beyond a facility, they are in the law recognized as the basic unit of healthcare delivery at institutional or facility-based and outreach, and they have a lot of legally defined roles and responsibilities. That doesn't exist everywhere. There's a regulatory framework that is actually devolving a lot of autonomy to these teams. The same thing in Honduras, although those are more public-private mixes. So all of these things are part of this world of policymaking that, yes, I tend to highlight too much because that's what I study, but they're very important in understanding the context and the differences. Now, therefore, the recommendations are going to vary based on those elements in context. Now, finally, in terms of the actual question, I think that little note about competencies that Bob captured is very important. If you look at the literature, in the last 20 years, there's so few articles about how to do this in low and middle income, especially in low income countries. And I would argue, Bob, that where feasible, yes, doctors should be part of the team. But wherever we do it, and again, I cannot afford to be normative, but it's going to sound normative. I would recommend that the competencies are built in an experiential way. This is not about getting a master's in health management or, I mean, if that is possible in the context, go ahead and do it. But the kinds of competencies that at least I have observed in the case of Honduras and El Salvador, in these primary care teams, there is not a lot of training, number one, but there is some, and let's recognize that the acquisition of skills requires some kind of training. But learning by doing, the way that adults learn, is a lot of what Mesoamerica has been doing with these ministries in these countries. There's very little money going to training, okay? Conventional training. But what Diego described as technical assistance, this is another area that is worth studying. What role do governments play beyond one-on-one supervision, which can be abusive, which can fail, which needs training also in coaching, but what role can district level offices and state level offices of the Ministry of Health play in actually conveying technical assistance to these teams? This is a major gap in knowledge. It's a big topic in high income countries. You're gonna see a lot of papers about what they call change agencies and stuff like that. That role is being played by Mesoamerica very carefully and very subtly, in a subtle way, with the ministries of health in these 8 countries. It hasn't worked everywhere, but more often than not, it has. And again, it's more about learning by doing, quick feedback, not about conventional training. Okay, I stop here.
Okay, I'm just gonna say, and I'm gonna steer the ground a little bit. Unfortunately, we have very little time left, but I think my take is a bit different. I think the first problem, at least in public health systems in Latin America, is that these are the only organizations where doctors do everything. So the only place where you can find people that can make sense of data is in epidemiology departments. But who's there for staffing decisions, supply chain management, all of these, we call them auxiliary services, but they are basically the pillars of the organization that keep it working effectively and efficiently. All of that is staffed by doctors that went up through the ranks and got there. But there are very few people that actually do have the expertise in these areas. And if you go to the middle and local levels, it's even harder to find these areas of expertise. So if we're not gonna change how the institutions recruit people, perhaps we need to start by changing a little bit the curriculum for physicians so they can learn some of these core elements so that they can at least understand the basics of what could make an organization work better. Thank you.
Thank you very much, Diego. You know, with COVID coming on the scene, telehealth has taken on such a huge dimension that I almost feel that policymakers are kind of saying, oh, we don't need to then have doctors at every primary health center level. Let's put all the doctors in a centralized call center and just make sure there's internet connectivity. And there you have it. You have primary healthcare teams of non-physician health workers and community health workers, and they can communicate with doctors through telehealth. Of course, time will tell us, but for COVID, this seems to have been the reality of it and the necessity of doing this. But you know, I guess those of us who are old schooled in the old primary healthcare alma mater kind of concept would find that a little bit difficult to swallow, about doing all medicine and all primary healthcare through telehealth. But I think we just have a couple of minutes left. So I thank you both very much for giving us such a fabulous expose, both into Mesoamerica as well as Wolfgang's evidence gap map, which has helped us identify what are the lacunae, and also perhaps for PHCRC to prioritize questions related to performance management that borrow from public management and new public management. So Manushi, over to you now. Thank you very much. Thanks, Wolfgang. Thanks, Diego. And thank you very much, Bob.
I want to extend a huge thank you to everybody who attended this session and for asking all these important questions. On behalf of PHCRC, we are sure to take it into account while we're discussing our research agenda and make it more relevant. All the recordings and the presentations will be made available. You'll get an email from me. That's it.
Thank you, everybody.
Bye, everyone.
Thanks,
Bye-bye.
everyone. Bye-bye.
Bye. Stay safe, everybody.